3 due to lack of quality evidence. So they are still not sure on inositol, what doses, how much, and how long to give. Now we come to the second important section, or maybe third. We've done lifestyle, we've done irregular menses, then hirsutism is pharmacological interventions, which is combined oral contraceptives, anti-androgens, or topical anti-androgenic therapy. Cosmetic measures, we all know, waxing, shaving, plucking, and direct hair removal measures like laser or electrolysis. Just one word on everything. Combined oral contraceptive pills. This is treatment of acne and hirsutism should not be withheld during ongoing longitudinal evaluation for at-risk PCOS. Now, suppose the girl is 15 years old and shows significant hirsutism or acne, but you've still not decided whether she is a PCOS. Any adolescent can have acne. Hirsutism, maybe not so much, but acne can be there. So please don't stop the treatment of acne and hirsutism because you are still not sure whether she is PCOS or not. Hormonal therapy should not be started before menarche. So only after her menarche, 1 year has gone, whether her periods are irregular or not so irregular. But if she has a lot of hirsutism, you can start hormonal therapy. When I say hormonal therapy, it is possibly OCPs. If response is suboptimal after 6 months, additional hair removal therapies or anti-androgens can be added. For moderate to severe hirsutism, hormonal therapy and anti-androgens can be started together. That means you give anti-androgens, which are topical anti-androgens, give hormonal therapy. Any estrogen-containing OC pill should be more effective at reducing acne, particularly for adolescents with premenstrual acne flare-ups. Those girls who get premenstrual acne flare-up, give them any estrogen-containing OCP, not the progestogen-only pill. Estrogen-containing OCP, and it will be very effective in reducing her acne. Anti-androgens which are available to us, now most of them are in combination with oral contraceptive pills because we do not want the girl to get pregnant when she's on this. However, a teenager in our country is very less likely prone to get pregnant. Maybe in villages, yes. So anti-androgens usage is spironolactone is the drug which is used in the USA most of all, because over there Diane is not allowed because of the DVT risk. 25 to 100 milligrams a day has lower risk of adverse effects. However, we need to combine something to regularize her periods in case they are also irregular. Cyproterone acetate and drosperinone are used as combination pills with OCPs. There are 1 or 2 preparations with drosperinone which has ethnyl estradiol of 25 microgram, and they could be considered, but otherwise these are second-line therapies for girls with hirsutism and irregular menses. Finasteride has an increased risk of liver toxicity. Dose is 5 milligram a day. So once the girl is on oral tablet of finasteride, it is important to do LFT every now and then, maybe every 3 to 6 months. Flutamide is not increased because severe liver toxicity is there. What are the OCPs? I've just given you this picture. You can take a picture of this drosperinone containing our Yasmin, Yamini, Chrysanta, and Yaz. Yaz is the one which has 20 microgram. Yamini, Dronis has 30 microgram of ethnyl estradiol, and so does Yasmin also have. But cyproterone acetate, all preparations have higher doses of ethnyl estradiol, 35 micrograms, whether it is available as Diane, Ginit, Crimson. And spironolactone has to be added with the OC pill to have more effectivity. But you can give it continuously, 50 to 200 milligram daily. It makes the periods very light. And in case the periods are irregular, they will still remain irregular with aldosterone antagonist, which is spironolactone. Topical eflornithine, this is available by the name of Vancua. And This is a cream, FDA-approved irreversible inhibitor of ornithine decarboxylase, which is an enzyme essential for hair growth. It can be used as monotherapy for mild cases of facial hirsutism or as adjunct to other therapies also. The effect is seen after 4 to 8 weeks of application, but if you leave this, then reversal of hair growth within 8 weeks of discontinuation. The dose is just twice a day application, at least 8 hours apart. So morning 10 o'clock and evening maybe 6 or 10, 8 o'clock. These are the trade names, and it is available on Amazon very easily. Mechanical laser light therapies, you all know more than I know. I've just brought a summary here that it not only reduces facial hirsutism, but it is very therapeutic for immediate depression, anxiety, and quality of life. In PCOS, they need more treatment sessions because there is a source of androgen production in the body of the girl. Idiopathic hirsutism requires less because here only the sensitivity of the hair follicles have been increased. And whenever laser is prescribed, please ask your person who's going to give what is the wavelength. The delivery of laser treatment varies by skin and hair color. It is ineffective in women blonde or gray or white hair. So in older women who start having mustaches which are gray or white, it won't be effective. In addition to oral contraceptive pills with or without anti-androgens, laser treatment may provide greater hair reduction and maintenance compared to laser alone. So mechanical hair removal with intense pulse light IPL could be considered, but the benefits are less pronounced. Management of hirsutism in a nutshell is that multimodal therapy is most effective approach to treatment of hirsutism, along with lifestyle changes, physical hair removal, and androgen suppression or blockage with medication that slows or prevents new hair growth. Hormonal therapy should not be started before menarche, and once it is started, take 6 months before benefit is seen. I always tell them, take a selfie when you're going to start it and take it 6 months later. You will know how much hair reduction is there, and very carefully make sure that the girl has not gone for any hair removal before she's starting the therapy. Then any estrogen containing OC pill would be very good, especially if she has acne also, because they are particularly effective for adolescents who report premenstrual acne flare-ups. And 3 to 6 months is when you need to see. You do not need to monitor serum androgen. If you know she is a PCOS, she is producing more androgen. Psychological therapy is very important. They have to be spoken to very kindly, these girls, even if they they're very obese, they look very rebel to you. You have to understand that they've become rebellions because of depression, anxiety, disordered eating, body image distress, low self-esteem. Psychosexual dysfunction should be offered cognitive behavior therapy where appropriate. Psychological therapy is considered first-line management, antidepressant medications second line, most probably only in adults, not in young girls. Lifestyle intervention other than therapies targeting PCOS features are important. Not managing anxiety and depression may impact adherence to PCOS treatment management. If you don't manage the anxiety and depression, they will not adhere to the treatment you are saying. They'll just leave and walk away. So to end, what are the ACOG recommendations for adolescent PCOS 2019? I started with ESHRI 2023. I'm giving you ACOG recommendations. It is hirsutism and acne should be taken seriously because of the effect on self-esteem and quality of life and the potential psychosocial morbidity. No clear consensus guidelines on the diagnostic criteria for PCOS in adolescents within 2 years of menarche, or I would say within 3 years of menarche. Thus, gynecologists should exercise caution in assigning this diagnosis prematurely. So if she starts menarche at 11 or 12, wait till 15 years and see whether her irregular periods persist or she is becoming hirsute or not. If the irregular periods persist grossly, then you need to do a serum testosterone to see whether she's got high serum androgen levels. Treatment of acne hirsutism should not be withheld during the ongoing longitudinal evaluation for possible diagnosis confirmation of PCOS. Finding of polycystic ovarian morphology on ultrasonography has a prevalence in adolescent girls 30 to 40%, where truly PCOS exists in less than 10%. So it is not predictive of the presence of future development of PCOS. Pelvic ultrasonography is not routinely indicated unless serum androgen levels or degree of virilization is concerning for an ovarian tumor, or the bleeding is not being managed by OCPs or progesterone alone. So what is follow-up of PCOS? Once you diagnose at an early age, tell her once a week you will take your weight. And when you find the weight going up on the weighing scale, it is then you will hold it. Ensure menses happens every 40 to 45 days. TT should be done yearly rather than fasting and just fasting glucose, or rather than HbA1c. BP should be checked yearly for these young girls, lipid profile yearly, and this is how adolescents have a long way to go, and wrong diagnosis can make their path difficult. Hence, please reserve the diagnosis to your mind. Do not disclose it to the girl or the family till you are sure that she has PCOS. Thank you very much.
Thank you so much, ma'am. Thank you. Thank you for taking our invite. I just wanted to introduce, I know you all know Dr. Abha Majumdar by now, but I don't know how many of you know that she's teacher of teachers and very passionate teacher. And she does not let go of any opportunity to, share her knowledge. This is the beauty of her existence, that she's always ready to share, and there cannot be any presentation from which you will not take at least one takeaway point. So whenever I hear to her at least one takeaway point, you will add on to your practice. Thank you so much, ma'am.
Thank you, everyone, for giving me this opportunity to learn. This is always an opportunity for me to learn a little more. Thank you, Niti.
Thank you, Abha ma'am, for your excellent deliberation on management of nuclear patient. I'm very sorry for joining a bit late. I was not free. So once I got free, I joined. And thank you, Dr. Anuradha, for giving me the opportunity. Ma'am, you covered each and every area of the PCOS problem so extensively, and the talk was very encouraging for me. So I congratulate you, ma'am, for this excellent talk.
Ma'am, Dr. Abha Singh, ma'am.
Yes, it has been an honor to chair the session where Dr. Abha Majumdar is speaking. And Madam, you have taken an elaborate session on adolescent PCOS, and with all the clear-cut key messages that when it is to be diagnosed, and what is the post-menarchal age at which we have to do sonography, not before 8 years, then when to use OCP, when to use metformin, and everything. So very clear-cut points and key messages. So thank you so much. It has been an honor listening to you. Thank you so much, Anuradha.
Thank you, ma'am.
Thank you, Abha. My name,
Yes,
Rashi.
seeing you after many, many years.
Yeah. Okay. All right.
Thank you, ma'am. Dr. Smita, we can go ahead with the next session.
Okay, thank you. Thank you, Abha ma'am. It was a wonderful lecture. And as we all know, PCOS is a multifaceted disease with its beings in every stages of life. So Madam has covered the PCOS in adolescence very beautifully. So now let us move forward for PCOS in reproductive age. So here PCOS and infertility. How to solve the puzzle? Here is also PCOS is a tangling disease. So for which to chair this session, I would like to invite Dr. Asha Jain Madam. Asha Jain Madam is a chairperson of FOXIC of Food and Drug Committee, and she is past President Rocks, and she is a renowned gynecologist and with ever enthusiastic personality. I welcome you, Madam. And Dr. Jyoti Jaiswal, Madam. She is professor and HOD of Department OBGYN JNM Medical College, Raipur. She is National Treasurer of IMS 2426, Vice President CG ISAR, Secretary General Raipur ISOPAR, Treasurer Chhattisgarh IAG. She has organized many international and national conferences and received many awards and recognitions, some of which Foxy Achiever Award 2023, Dr. Suvarna Khalitkar IMS Best Committee Award 2021. I welcome you, Madam. And Dr. Anuradha Tibriwal, Madam. She is presently Secretary of CG IFS chapter. I welcome you, Madam. And to deliver the lecture, I would invite most awaited Dr. Bharti Dhoripatil, Madam. She is HOD Sri Hospital, Pune, IVF Consultant Nova Fertility, Pune, National Vice President IFS, National Vice President FOXY 2016, President POX 2018-19, past President IMA Pune. She is the founder, Chapter Secretary Maharashtra, Chapter IFS, Executive Editor Journal FSR, Fellowship Guide, Postgraduate Reproductive Medicine Fellowship IFS ICOG, Pune Women Icon 2014, Foxy Star Awardee 2016. I welcome you, Madam. Please.
I think I'm sharing the, yeah, I would like to share it. Is it coming?
No, ma'am.
Did you see? Huh?
No, ma'am.
No,
Not
ma'am.
yet.
Oh.
Not now.
I don't know how many of you are aware of the spiritual aspects of Dr. Bharti Dhore Patil.
Can I,
When she talks about
can
Gita,
somebody
and when she
give,
talks,
can
talks
somebody give me an email ID? I can send it to the email person because
Ma'am, I'm making you as a co-host, so you can share.
no, it is not possible. Some problem is showing here.
I am giving you my email ID. I will on.
You chat box, you just write your in the chat box.
In WhatsApp, I am sending, madam, within second.
Okay. Anuradha?
हाँ मैम हाँ मैम
उनके साइड से प्रॉब्लम है यहाँ पे सब
नहीं, आपके
tell them
आपके
take
साइड
us-
में प्रॉब्लम नहीं है, यहाँ पे हो गया है some problem.
अच्छा.
I don't know what. On the same our okay.
I have sent you, ma'am.
Okay.
Neeti ma'am, meanwhile we are arranging, please enlighten the spiritual aspect of Bharti madam.
Dr. Bharti.
Connection.
So I got to listen to her 2 or 3 times, on different fora, and I realized, because I always knew ma'am as a great academician, and all her talks have been very, enlightening. But when I heard her to the spiritual aspect of her, I realized that, she's off finally there, right, ma'am?
That's
Ma'am,
there. Let me just share this and then I will talk to you. Just a minute. Just give me little time. Yeah. ये पूरा दिखता है इसके कंधे का जो पिछला हिस्सा है ना इंटरेस्ट हाँ ये
Dr. Anuradha, you please tell your team to make me also co-host, because I have to share for the next session.
Yes, ma'am. Yes, ma'am.
Yeah.
I'm telling.
Hello, ma'am.
Ma'am,
Hello, Bharti, ma'am.
ma'am, have you sent, ma'am?
Hi.
Ma'am, you have sent in my mail ID, ma'am?
Yes, it's Doc Anu.
हाँ Doc Anu. हाँ yes, ma'am. Same.
Okay. Doc Anu 4, na?
Yes, ma'am. For you.
Then yeah.
अच्छा बन गया बस
Delegates, please, if you have any questions, you can write in the chat box. We will take them whenever we have time.
I think Dr. Abha's lecture was so, elaborate about, she touched all the aspects of adolescent PCOS so well. So maybe that's why. Dr. Sushma ma'am, please आप mute कर लें.
Hello, hello, ma'am. Hello, ma'am. Actually, it was heavily raining in Pune. So, ma'am is telling we used to start the panel discussion first. Then, after little bit less rain, then she will join again.
Okay.
So, ma'am.
Anuradha, I am also having some network issue here.
Okay, ma'am.
It's raining in Moa and having some network issue.
Yes.
I have joined since the beginning, but not able to start my video.
Yes,
On
ma'am.
you, only I can hear the audio part.
Yes,
Madam, on your side, please check it also, because everyone's video is visible.
Yes, ma'am.
Can you see my slide now?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Okay. So
Sunita,
now we
will
okay now.
panel.
Sure. Now we will move forward for our panel discussion, which is very practical. Should we
Sunita,
move for panel discussion?
am I audible and visible?
Yes, Shushma ma'am, you are
Okay,
audible
okay.
and visible both. Yes.
Okay.
Right. So
I
we are
have
moving
checked.
forward for our
Okay.
panel discussion. We have some problem with Pune network, so madam will deliver a lecture after the panel discussion. So, so for this interesting panel discussion on challenges in resistant PCOS, I would like to invite our experts, Dr. Sarita Agrawal, madam. She is hello. Anyone telling something? Okay. I'd like to invite Dr. Sarita Agrawal, madam. She is Professor HOD in AIMS Raipur. Dr. Monica Pathak, madam, she is President ROGS. And Dr. Shushma Verma, madam, she is Executive Member ROGS and past President IMS Raipur chapter. And to moderate this panel, I would like to invite Dr. Neeti Tiwari, madam. She is Senior Consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi. She has presented many papers in national and international conferences, teaching guide to FNB, and she is Executive Member IFS 2224, Co-Convener IFS SIG 2224, and Convener IFS SIG 2426. I welcome you, madam, and to accompany her, I'd like to invite moderator Dr. Parul Garg, madam. She is presently working as Head of Department of Medicine at Artemis Hospital,
Dr.
Gurgaon,
Sunita, just say two
executive member
lines.
of IFS
Say
2226.
two lines
Yes,
about
ma'am.
just introduce
Okay,
everyone with
okay.
2 lines only so that we can start.
Yes, sure, ma'am. National Coordinator, Male and Female Infertility, Real and Beyond Antioxidant IFS. I welcome you, madam. And madam, would you like to invite all the panelists, or should I?
No, I would like you only to invite them, Dr. Sunita.
Okay, ma'am. Okay. I'd like to invite panelists Dr. Anupama Ravi Petula, ma'am, Dr. Shalini Jain, ma'am. She is Director of Saubhagya Mother and Child Care and Advanced Gynae Endoscopy and Infertility Center in Raipur. Dr. Veronica Yuel, madam, she is a renowned IVF specialist in Raipur. Dr. Vinita Singh, madam, Associate Professor in AIMS Raipur and very dynamic personality. Dr. Lata Goel, madam, and Dr. Ruchi Ruprela, madam, she is renowned consultant gynecologist in Raipur. Dr. Jitendra Behra, Dr. Benashri, ma'am, she is a HOD RIMS in Raipur. Dr. Prabhadeep Kaur, madam, Dr. Shashi Bala, madam. I welcome you all, madam. And now I hand over mic to Dr. Neeti Tiwari and Dr. Parul Garg, madam.
Good afternoon, everyone, once again. So, are all the
Good evening,
panelists
ma'am.
there? Are all the panelists there? I just wanted to
Yes.
confirm.
Yes,
Dr.
ma'am.
Anupama,
I
Dr.
think two panelists are not
Yes,
there.
ma'am.
Dr. Vinita Singh and Dr. Bani Sri is there or not? I am in doubt.
I'm there. Dr.
Yes,
Bani
yes.
Sri is
I
here.
saw her
Yes,
name.
Yes.
she's there. She's there.
Banishri is there. So we have a galaxy of very senior gynecologists from Raipur. Welcome all. And in this panel, what we are going to do is we are going to discuss some tricky situations of ovulation induction in PCOS. We are not only going to follow the guidelines which are there, but also discuss from our clinical practice what has helped us when we encountered this situation, what helped us, so that we make we learn from each other. That is the idea of this panel discussion. So with me, Dr. Parul Garg is there, and Dr. Parul Garg is also co-convener of the SIG PCOS. So, Dr. Parul, you can take the first case.
Yes, ma'am. So good evening, all. Thank you, ma'am, for inviting me. I will start the case one. So Mrs. X is 28 years and Mr. Y is 30 years, married for 4 years, trying to conceive since 3 years, and menstrual history is 4 to 5 days. It occurs at every 2 to 3 months since the age of menarche. And patient often takes withdrawal treatment with the progestogens. And there is a coarse dark hair growth on the face and lower abdomen and arms, which has progressively increased for the last 2 to 3 years. And patient also complained of progressively worsening acne on face and back. The family history: mother is diabetic. BMI was 32. BP is 130/80. And on examination, there is acne, hirsutism, and acanthosis nigricans. AMH was 6.8, HbA1c 5.9%, lipid profile was normal, thyroid prolactin were in normal range, and tubal patency test, semen analysis reports were normal. So on ultrasound, uterus was normal and both ovaries showed PCOS picture. AFC is around 20. Now, patient has tried 3 cycles of letrozole. First cycle was 2.5 mg and next 2 cycles was given 5 mg for 5 days. And there is no ovulation. So how will you manage her? I mean, the first step is lifestyle modification. So Dr. Anupma, can you please let me know, this is a patient of now letrozole resistance. So what is the role of lifestyle modification?
Hi, thank you for that question, Parul, and thank you, Anuradha, for having me here. It's a pleasure being amongst one of your friends and taking that question. Well, this patient is a clear-cut patient of PCO variant because she's having all status of hyperandrogenemia as well as an ovulation. So all that is very clear. We have already treated her, giving her the first line oral management of letrozole. And despite giving 2.5 milligram and further extending it to 5 milligrams, the patient has not responded. I'm very sure that lifestyle modifications, weight reduction, because her BMI was around 32. So that
32.
weight reduction was definitely advised to her. And lifestyle modification is a very important thing in the sense that her mother is also diabetic and she is carrying that genes of insulin resistance. So that insulin resistance, the obesity adds to that insulin resistance. So she has to take care of her weight. Moderate activity at least 3 times a week. That is the must activity which she has to do. Anything beyond that is most welcome, but at least 3 times a week for at least half an hour, moderate activity is advisable for her. Apart from that, if despite the sometimes you do not want to linger on for weight reduction for months together, this has to go along with your further medical management. The weight reduction thing should go simultaneously, and there is supposed to be a role of metformin too, because that would improve her insulin resistance a bit. And that metformin, if we add, since there is a GI side effect with metformin, we have to gradually escalate the dose. We'll start with 500 BD, and then gradually, as the patient, if is intolerant, then we have to stop. Otherwise, we can go up to a higher dose too. And that should help her in her weight reduction. Also, in her improving her insulin resistance, that would help her in not having an ovulation. Apart from that, I would also want to extend my treatment in the form of extended letrozole, and I have a very low threshold of giving gonadotropins in such patients. Maybe
That is the
she's
next
very
step, Dr. Anupma.
fine.
So yeah. So you will prefer metformin or inositol?
I would prefer metformin. Myoinositol is still, you can give it simultaneously, but its role is not still proven. The
Yes,
guidelines
yes.
do not
Yeah,
endorse.
guidelines do
Although
not.
the preparation which I'm usually using is having both metformin and myoinositol in itself. I think the drug which I use is Metital. So that has both of it.
Okay.
But what I'm really targeting is metformin, and I'm
But
not a big fan of
But
myoinositol.
simple metformin, we can increase the dose. If you are giving a combination, then you give
You
the,
cannot.
you
Yes,
cannot.
yes.
Yeah.
Agree.
So maximum dose is up to 2.5 milligram to 2.5 grams in adults and adolescents, 2 grams.
Yeah.
Okay, Dr. Veronica, do you want to add something?
No, I would prefer to go with
There is one
metformin
question.
only.
There's one question because what I saw in Raipur, because you all are getting, women with surrounding rural areas also. When we talk about lifestyle intervention, how do you explain moderate exercise? What kind? How do you, just telling them to do a moderate exercise for 30 minutes sometime, we have to objectify it and tell them, how to do it.
Yes, we have to describe. What I usually do is I describe them what sort of exercise they should be doing. One thing is more important is we have to reduce their belly fat. Exercises should be aimed towards that. So more of weight, where they have to have a weight bearing exercise on the tummy to reduce their fat. Also at the same time, they have to mobilize the fat. So what I persist, if they are going to a gym or so, I tell them that they have to lift weight kind of thing. Just some of them, what they do, they just keep walking or they do cycling, and then they
Yeah.
prefer. So we have to select those exercises and explain them to which will benefit them. Secondly, when I explain them, like some of them, they go for walking, so it has to be a brisk walk for at least 20 minutes or 30 minutes. That has to be explained to them that they should sweat. Only when they burn their fat, they should sweat it out, then only. Kuch log na sirf टहलते हैं,
Healthy.
and
This is
then
what
they
I
say yes, and then they say that we are going for walks but weight कम नहीं हो रहा है. So you have to explain them. उनको उनकी भाषा में समझाना है कि भैया तुमको मार्च पास्ट करनी है आधे घंटे, जिससे कि you really sweat out and then come and have your breakfast, which should be like break your fast. Don't overeat after an exercise. So this is how usually I explain them, that you walk. And initially when these patients know, they come and tell हमको सब पूरा body ache हो गया, हम walk नहीं कर पाए. So exercise has to be gradually increased over time. एकदम से उनसे आधा घंटा या एक घंटा वॉक नहीं होगा, या आधा घंटा या एक घंटा एकदम से एक्सरसाइज नहीं. वी ऑल्सो हैव टू एक्सप्लेन देम that please initially start with 10 minutes, increase it to 15 minutes, then 20 minutes, then 30 minutes, then 45 minutes. So over a time period of, may say, 1 month or so, they will get into the regular practice of exercise. This is how we have to explain them in detail.
Very well said, Dr. Monica. You have
Can I add something here? That when I was reading through it, there was one interesting thing which came over, that what is a mild, moderate, and intense exercise? The mild one is the one in which you can sing along with that activity.
Wait, मैं बोला हूँ.
And the moderate one is the one in which you can talk along with that activity. और जिसमें हम दोनों ही ना कर पाए, that is the
That is the
intense.
intense.
That is when you are doing intensive. Very, very well
That you're
said.
doing. And
मुझे
what
बड़ा
is the
अच्छा लगा था
role
ये.
of diet?
So diet also likewise we have to similarly explain to them, like abhi off late intermittent fasting का बहुत सारा. So what people think, हम दिन भर तो कुछ खाए नहीं, रात में जाके खूब खा लेते हैं और उसके बाद immediately सो जाते हैं. That is what is exactly
that is more important.
not correct. Right. So I have just yesterday only, I have had a 100 kg obese girl who is 13 years old. And the mother is coming and fighting कि वेट तो रिड्यूस ही नहीं हो रहा, हम उसको जिम भेज रहे हैं. वो दिन भर उसको भूखा रखती हैं और रात को उसको पनीर चिली बना के देती हैं. So how she will gain lose weight, अब आप बताइए. So they also have to be explained that even the diet has to be like a typical PCO diet is, like give them small frequent meals.
An
Even
early
if-
dinner.
Yes, an early dinner. And do not sleep after dinner. They have to sit, do something, some activity, don't sleep immediately after dinner. So they have to be explained the dietary pattern, what sort of a diet they have to take, how they have to take. Initially when I was taught and I was learning, I was taught small frequent meals. इससे आप खाते तो ज्यादा हो, but then your actual metabolism is not much. मतलब जो actual हम लेते हैं, that is not much.
So basically, lifestyle modification is a combination of behavioral therapy, dietary, and exercise.
Yes, yes, yes.
So
It
we
it
have
is a
to
teamwork.
tell, and this is very important. We have to tell what type of exercise they have to do and what type of diet. They have to have an early dinner, low carb. I don't say high protein, but it should be a balanced diet.
It should be a balanced diet.
It should be a
Right.
balanced diet. Now, next question comes the role of metformin versus inositol, which Dr. Rukma has already told. I just want to ask each and every panelist what they are using. Dr. Shalini, would you prefer either metformin or inositol?
I prefer metformin.
Okay.
Because it is, inositols are just a nutritional supplement kind of thing, and the evidences also doesn't support this. So metformin acts at all the levels.
So in
It
every
occurs-
PCOS patient, you are starting having metformin?
Not exactly, because this patient is infertile, so we cannot start OCs on this. But for hirsutism and hyperandrogenism features, which patients are having, I prefer COCs. And for metabolic derangement वाले patients, जैसे इनमें BMI 32 है, mother diabetic है, so I will go with metformin because she is not responding to letrozole also. And it is a kind of cogonadotropins. It is a assistant to gonadotropins, and even if we start this patient on gonadotropins, she will respond well after starting metformin. So it will act, yeah.
Because of their metabolic beneficial effects.
Yeah.
And Dr. Ruchi, can you do you want
Ma'am,
to?
I would like to differ in this case. Metformin, I agree that metformin has a role in improving the glycemic index and it has a better control in central obesity and hirsutism. But studies are there that myoinositol does have a role in improving ovulation along with the ovulation inducing drugs. So I do write the myoinositol along with the ovulation inducing drugs.
So you prefer inositol over the metformin?
Yes, ma'am, for ovulation. But when it comes to hirsutism and hyperandrogenemia, then metformin works better.
Okay, fine. Dr. Lata?
Yes, madam. I also agree with Ruchi, madam. I prefer to give both metformin as well as inositol, uh, depending on the condition. As in this case, I prefer to give metformin, but in many other conditions, I used to give inositol along with the ovulation inducting drugs.
And what
Because
is it?
it helps in ovulation. So I used to prefer with ovulation induction, I used to give inositol. But in this type of cases, as there is hirsutism and acne, I used to prefer metformin.
Okay, fine. And what is the dose you are using in inositol, Dr. Lata?
1 gram.
1 gram per day.
1
And, okay, fine. Is Dr. Jitendra is here?
Yes, ma'am.
So,
Yes.
what do you want to add?
No,
Metformin, inositol.
usually I used to start inositol for most of the patient, but
Okay.
see the profile of this kind of patient where like the high risk for the diabetic and insulin resistance because the family history is there, and moreover she is obese, so definitely I used to add metformin. But initially 1 or 2 cycle I don't add even if this kind of patient I will get. But if still there is like an ablation and all, then I used to add because metformin itself having lot of GI side effects and all,
Yes,
and most of the people then even if you tell that you take it regularly, they will skip it and they will tell lie that I am continuing like that.
So
So
whenever the patient of PCOS comes, irrespective of BMI, so you start insulin sensitizer. I mean, in every patient.
Yeah, so Parul, one question we can ask here, that in which lean PCOS are you giving metformin to all lean PCOS?
Yes, that's why I'm asking, irrespective of BMI. I mean, what they want to
high AMH we can give, and if there is any abnormal GTT like those kind of patient, apart from high BMI, if it is lean PCOS, even if the AMH is high, we have to give metformin.
Yes.
So when it comes to obese PCOS, it is quite clear that metformin will benefit.
Yeah.
It will add on to the lifestyle intervention. But the question is in lean PCOS, because this is a drug which has side effects, it has GI side effects. So yesterday only I was talking to my endocrinologist friend, and he came up with one thing which was very interesting. He said that what we are doing in our practice is that we are doing GTT, okay, to look for any insulin resistance, we look for GTT. He said that you should get a fasting insulin done also. So you can have a higher fasting insulin despite having a normal GTT. So this woman will have insulin resistance, but it will not show on GTT. So such kind of women, even if they are lean PCOS, can be given metformin.
Yes. Now,
interesting point.
Evidence-based also says that metformin can be given in the lean PCOS when BMI is less than 25, although there is a limited evidence, but we can give metformin, irrespective of BMI, because of its metabolic beneficial effects. And anisotol as such is under research. There is no safety profile and there is no, we don't know about the exact dose. So it's a secondary. First is the metformin, according to the evidence. So next. So what are the other treatment options? Like the patient has letrozole resistance, already tried this lifestyle modification, has started the insulin sensitizer, and patient is not responding. So now we go to second line of treatment. So Dr. Prabhadeep.
Ma'am, Dr.
Prabhadeep
is absent, ma'am. And
Okay,
Sasiwala also absent.
Doctor Shashival. So Dr. Banishri.
Yes, ma'am.
Yes. So
Yes,
what is
ma'am.
the second line of treatment?
Second line,
On your video,
if
Dr.
we say,
Panishi,
Yeah,
if
she
we
has
see
on.
the literature also, second line we can have two options, ma'am. Either we can go for a gonadotropins, alone gonadotropins, or maybe gonadotropins along with the combination, but combination of clomiphene sometimes, or you can have options of laparoscopy. But first and second line is considered always as a gonadotropin, madam, what the literature says.
So how you start the gonadotropin? Suppose there is a HMG or recombinant. So what you will prefer?
Actually, if we see the evidence, madam, both can be
both can be started. There is not much difference between both recombinant and HMG. Both can be started safely. From the low dose with a low dose step up for the monofollicular growth. Our aim is to keep a monofollicular growth to avoid the multiple pregnancy. Mainly that is the aim. So we can steps up from the low dose to higher under monitoring.
So it's a low dose step up regime. And Dr. Veronica, you want to add something?
Yeah, it depends on what I am stimulating for, number one, and the patient profile. If I'm stimulating her for IUI or ovulation induction, my aim is towards a monofollicular response. So, and also if I'm stimulating her for simple ovulation induction or IUI, I also have to keep cost factor in mind. So, in such cases, I prefer to give HMG only because that's cost effective as well, and data also says that there is not much of a difference between an FSH and HMG. Now in very hardcore PCO where there is already an endogenous elevated LH, such cases what I usually prefer, I try to give them OCs for 1 or 2 cycles so that the endogenous LH come down and then give them HMG. Or else then in the or in worst scenario then I prefer to give FSH. But then FSH, if I'm giving, I would prefer to give them a recombinant there, considering if the patient is able to afford and all. But for ovulation induction, for IUI, for all practical purposes, mostly I use HMG. Now, when it comes to IVF, if I have to stimulate for IVF, I do follow a low dose protocol, and there I'm using recombinant.
Yeah, actually, this is only on ovulation induction with IUI. So we
Right.
are
So
not.
in that case, I find no difference between an
Okay,
HMG and
there is
FSH.
no difference HMG and recombinant.
Yes.
And
So I have
protocol will
used
be.
urinary ones only.
Okay. Dr. Shalini, want to add something?
Yeah, I agree with Dr. Veronica. I will start, but I will also add letrozole along. Still, she has been given 3 cycles of letrozole, but still I'll prefer to go with letrozole plus HFG. And
So
I will
letrozole, HMG from the second, third day of the cycle or the sixth day?
no, from 6th day of the cycle, I
Okay.
will start her on letrozole, and I will be preferring to use letrozole extended protocol, that is for 8 to 9 days.
Exactly.
Yeah.
In fact, I have given those who have not responded to the conventional 5 days letrozole.
Yeah,
I have
exactly.
actually tried 2 types of giving. One is the extended one. I have even tried extended clomiphene, right? That also has worked in these patients, and also the step up letrozole protocol also.
Yeah, it is
First you give
2.5
2.5, then 5, then 7.5, and then up to 10. That
10? Okay, 10
yes,
is very high.
yes.
Yeah, the extended letrozole protocol for 9 days, the patient respond very well along with HMG and follicular monitoring.
No,
Whether
that 10
it is
is
for
only for a day. The step up
whether it is for
protocol that I use is very particular. 2.5 on day 1, then 5 mg on day 2, 7.5 on day 3, and 10 mg on day 4. That is only for these these things. So
Finishing
I have got a good response in these kind of patients. This is
Ideally,
something
the
different.
You
stair
are
step.
stepping up every day. You are stepping up every day.
Yeah, stair
Yes,
step
I'm
is.
stepping up every day.
Stair step is you are giving the 2.5 milligram for 5 days and do the ultrasound, and then 5 milligram for 5 days and then 7.5 milligram for 5 days. That is a stair step approach. That is
See,
there,
it is okay if it is helping her, Dr.
but
Veronica.
it's
We can
helping.
also.
It's a new.
Yes. That I have. In
Basically,
I
what
fact,
just
happens,
this we
I
have
just
been
want to know
using
one
since.
thing. I just want to know one thing, that when you are giving such high doses of letrozole or you are giving extended letrozole, have you encountered any big breakthrough bleeding or thin endometrium? Have you encountered that?
No, with
Because this is the
clomiphene,
problem.
yes.
You
With
know what?
clomiphene, yes.
Because
Not with letrozole.
Okay.
actually what happens is that and we actually letrozole you can give even up to 7.5. In this patient we have stopped after 5, but 7.5 also you can give for 5 days. But why we are not usually giving 7.5 is that we find that the E2 goes so low. When you give
We
letrozole
found
7.5,
thin endometrium.
E2 goes so low that sometimes you have breakthrough bleedings, or I don't know whether you people have encountered or not, but even in letrozole cycles you can have thin endometriums.
I have
Uh,
also find a thin endometrium in the letrozole.
We have
Yeah.
encountered that
I
also.
would like to add something here.
dose of
In
letrozole
endometrium,
and the
no,
longer duration. then you can have those issues.
Madam, I used to give 2.5 for 7 days, and then on 8th day I used to do ultrasound, and if required I used to add HMG 150 for 3 days. Then on 14th day there are good number of follicles of about 18 to 20 mm.
Okay.
The thing is, the
Ma'am, I
purpose
want
of
to ask.
adding or extending the letrozole is just one, that the FSH is being raised. Why do we give letrozole at all? We give it because it acts as an anti-estrogen, and because of that, the level of FSH is supposed to be rising. Now, if you are not getting a response with 2.5, the meaning is that it is insufficient to give the pituitary that stimulus. So we are extending it to a higher dose. Say, supposing we are giving 5 milligram dose, as in this patient. Still, we do not get the response. Then we are going up till 7.5, which is fair enough. But we have to gradually escalate it. That is what I want to give a message. In a day, maybe if you're getting results, getting too fast is okay, but the purpose of this is gradually escalating,
That is
and
more important.
getting beyond the FSH level should go beyond. And even if you are going up till 10 mg, if the follicle is finally getting stimulated, then the follicle will produce estrogen. And I have seen these patients recovering their thin endometrium. What Neeti, you were saying was that you do encounter thin endometrium in letrozole patients also. I have seen it so many times.
Yes.
But I have also seen that the lining does improve after a while. Say 13, 14 mm the follicle goes. After that, the lining comes back. It regenerates now.
And
the
that
proliferation
is
happens.
And that is true with the breakthrough bleeding also, which you have. So if the spot, it is only spotting and some amount of bleeding, you just continue with the cycle, and the endometrium,
Yes.
and the endometrium recovers.
It recovers, yes.
Yeah.
Ma'am, I want to ask one thing. When we start HMG, as you said, from day 6, so should we give it on daily or we have to give it alternate days?
It depends. Depends on
It's
the
a very
response.
variable answer. You
But
have
it
to
should
follow
be
the.
it should be daily one. Prefer daily. And you have to do a intensive ultrasound monitoring also.
Yes. I have
So,
even gone with recombinant also in stubborn patients, and have got results when nothing else is working. The recombinant does work. But of course, in those patients, I have a very low threshold of adding even an tag. If more than one follicle comes up, the estrogen level gets really high, and just to avoid the LH
Actually,
ceiling, we have to
these
add the attacks.
ovaries
These are very
respond
costly
to
affair and
these
not for routine
ovaries.
stuff.
Yes.
So, okay, so
No,
we
these
have
ovaries respond to very stringent doses also. Only thing is we have to be patient, and also
Yes.
at the same time counsel the patient also.
There is a
कि
very
तुम रुको,
thin line of threshold.
आएगा
Yeah.
response उनको
Ultimately, जो
समझाते रहो
chronic
बस.
low dose protocol है, it actually works. It's just that it tests
Yes,
your
it
patience,
works.
nothing else.
It works.
You and the patient has to be patient.
Yeah.
And secondly, Joe, the step up protocol that that I was telling, I mean, I step it every day and I give it only for 4 days.
Okay.
We have actually done a thesis on that. This was my colleague's thesis topic, where we got at least 2 to 3 good follicles, and she was stimulating for IUI only. So that is what built our trust on this, and I've been using it over last 10 years. With absolute, I did not have any breakthrough bleeding, got a
Nice.
good endometrium, and the response. Try it in your practice. I think I mean the response also comes out to be good in
Right.
such cases.
So in this we have started with the recombinant injection FSH. We have given 75 for 7 days, no response, and then increased to 100, 150, and maximum 225. So there is no response. So what next? Dr. Jitender?
Madam, actually, frankly speaking, like after listening to so many discussion, I will tell my experience. I always prefer this extended letrozole protocol, and it has worked out for a lot of my patient. And I used to use only 2 or 3 maximum gonadotropins in a cycle, not more than that. And
You say
especially
extended, how long?
Extended means, I mean, how many
Madam,
days?
7 days. 7 days, madam.
Okay. 2.5
7
milligram
days.
for 7 days?
7 days, and day 7 I used to give one gonadotropin HMG, that is 150 or like 75, depend upon the BMI and all. And again, I used to call the patient on day 11. And if I have found most of my patient, for minimum it should be 14 to 15 millimeter. Then again, one more gonadotropins I used to give and call them after 2 or 3 days. Definitely, it works out, and it is like 18, and like according to like you said, like regarding the thin endometrium and all, I have never encountered in like very rarely, maybe 1 or 2
But
patients.
such a patient which is so stubborn, 150 FSH also she's not responding. Do you think 7 days
Yeah, so
later
this is a
will work?
stubborn patient.
It's a really
Yeah,
stubborn.
so we are talking about very stubborn resistant PCOS, Dr.
Yes.
Jitendra here. You
Now
know?
she's
Yeah.
gonadotropin resistance.
Yeah.
Now
Yeah,
what's
yeah.
next?
Up to
Okay, madam.
225
Madam.
In
days,
that patient, ovarian drilling works. Like
Yeah. After
laparoscopy and
this, definitely we have to
laparoscopic
go for
ovarian
ovarian
drilling
drilling.
works.
Exactly.
So there is also slides on ovarian drilling. So when we offer a patient to ovarian drilling, so second line of treatment, either ovarian drilling or a gonadotropin. So we have
Yeah.
discussed about gonadotropins. So when you advise a patient to
Yeah,
have ovarian
yeah.
drilling,
So there is
Well,
three things, madam. There, if there is like resistant clomiphene citrate like 6 to 9
yes,
cycle.
hmm,
Second thing is like BMI should be less than 30,
yes.
and LH should be high, like should be more than 10. So if these three things are there, then definitely we should go for the ovarian drilling.
So you will go for ovarian drilling first and gonadotropin second in these patients.
No, no, no. I will first go for gonadotropins.
no,
Because
Parul, we are already gonadotropin resistant now. So he's
Yes,
yeah.
saying
yes, yes, exactly. Already we have given.
no,
So
no.
we are back to ovarian drilling now.
Yeah, yeah. Then I will go for ovarian drilling. Yeah, right.
So obviously ovarian drilling have a various
Good option.
advantage. There is no ultrasound monitoring, and we have a monofollicular development. And although there is a risk like intraoperative and post-operative risk, we have to counsel that patient. Now this patient is a gonadotropin resistance that is there. Now what is the next? Dr. Banishri?
Would anybody like to investigate her more?
I mean, what is next? Why patient is having a gonadotropin resistance? What we can do next step? I mean, what are the
Well, we should
investigations we
watch
can have?
for delayed onset congenital adrenal hyperplasia.
Yes.
That could be one of the reasons why this late, 2.225 is too much of a dose for a normal
Yes.
cycle and patient not responding. So sometimes adding dexamethasone would add to
Yes.
be of benefit.
So at this point, actually, it will be a dilemma, madam. She needs to reevaluate once again. As sir told, we have two options at that point. At second line, once gonadotropin fails, before taking for a laparoscopy ovarian drilling, we need to reevaluate what is the cause. So because gonadotropin, when they are not responding, then maybe once again whether she has gone for a premature ovarian failure, because gonadotropin they should respond at that point. Maybe I feel once again we have to reevaluate, and we have to, after exclusion everything, we have to go for a laparoscopic ovarian drilling.
So
So
what
again
investigation?
laparoscopic ovarian drilling.
Receptor polymorphism testing can also be done if
Yes,
the
yes.
they are resistant at the receptor level.
How do we do that? This receptor polymorphism test?
It can be
Can be done now. It
Testing
can
is
be
done.
done.
Gene testing is possible. FSH receptor polymorphism can be tested.
So,
It can be done.
sometimes
It's
people
available
say,
in some labs.
sometimes people say that they have never encountered such a very resistant PCOS. But I remember in initial days of my practice, if I tell you, there was this lady to whom I had given 300 unit of gonadotropin and she did not respond. And then she stopped coming to me, and then after 2 years she came with twins in her hands, and she had gone to some other center and got a IUI done with donor oocytes. So there is a group of very resistant PCOS, but we should know how to deal with them. So as Dr. Anupma said, here comes the time to, because if you remember, this lady was quite androgenic. Okay, so one has to look for 17 hydroxyprogesterone,
Progesterone and
DHEAS. And as Dr. Veronica was saying, even I do that in my practice, though there is no evidence now. There are a lot of papers on this that high LH does not matter. in PCOS, you don't have to suppress LH. In fact, you don't have to even see LH. They say that you don't have to even see LH baseline and you don't have to suppress it. But yes, in these kind of very resistant PCO, when you find a high LH, one can think of giving 2 cycles of OC pills, continuously before giving a, ovulation induction.
Ma'am, Bharti ma'am, please you can give your valuable inputs, ma'am.
So next,
Can I
now
know
comes
what is that patient's AMH?
AMH
AMH?
6.8.
6.8. 6.8.
Now,
These
once
are
the
the
AMH is 6.8, this patient should not go for ovarian drilling at all.
obese है, hyperandrogenic है, obese है,
ओवरिन
hyperinsulinemic है,
ड्रिलिंग होना नहीं, सी उसको ओवरिन ड्रिलिंग नहीं होना चाहिए because this is a high FSH. This is probably a case of LH ceiling effect because of the high LH level. What happened? You are giving FSH, but still it is not been overcoming the ovarian her threshold. Because of the threshold she is not crossing, this can happen, and this is very, very, very commonly it is been seen nowadays, the patient. So this patient doesn't have high image. 3.5 to 6 definitely responds very well with your drilling. But then this patients, when it is high FSH, this patient will not be useful for the drilling. She will have.
her FSH is not high.
FSH is not mentioned.
We haven't done FSH and LH. We haven't done the FSH and LH in this patient.
It's written here high FSH and high LH. That's why.
Ma'am, this is a further investigation. What we can do if the patient is having a gonadotropin resistance.
Suppose this comes, it's just a imaginary situation.
Imaginary situation, yeah.
Okay. No, but this is okay. What she says, this patient will not work as a lit, as one of the panelists was saying, it will not work as a latrose. Definitely, if she will require a high doses, probably still more high doses, and maybe this patient will require, as Dr. Niti was very correctly saying that maybe you pre-treatment is very necessary for this patient. So pre-treatment, maybe 1 or 2 cycles of OC pills and see that LH level goes down, high androgen level goes down, and then start with the, how much dose you had given? 225.
We have gone up to 225, ma'am.
Yeah, you start with 225 or maybe 350. So start with that dose. If it is a IVF patient, this high threshold will take over her LH ceiling, and then you will have a better response in this patient. These are very typical resistant PCOS patients. Actually, I would have shared one the patients. And adding to dexamethasone truly doesn't make much difference. Doesn't make
any role of dexamethasone?
No, it doesn't. Actually, what makes a difference in this patient? Growth hormone. If you add a growth hormone in this patient, excellent results. Excellent results. So growth hormone makes a lot of difference in these patients. So adding, rather than dexamethasone, add a growth hormones in this patient, resistant PCOS, excellent response for these patients. So this is what
it will add the cost, ma'am. Growth hormone is very expensive. Per unit you have to per day.
But time has come, life and death for her.
Yeah.
She has to have
but
the
when we are doing IUI, then we have to think of adding a growth hormone.
IUI, I know. IUI, I definitely I know that IUI you cannot add. But do you know that growth hormone, how much it costs?
Okay.
You have to give 8 days, that is one pain comes, and that is 8,000 rupees. One pain. One pain only. And that is only just 8,000 rupees, 2 units. Don't give much.
2 units, okay.
These
fine.
patients, they will not require low dose growth hormone, 2 units per day for first 8 days. That will require 8,000 rupees plus. So somehow you convince her, that makes a lot of difference in these patients. And nowadays I have started this resistant PCOS patient doesn't get pregnant also very easily. They will require down regulation with FAT, and that makes difference. Now we are presenting that cases, publishing that cases.
How
that
you
is
down regulate, ma'am? How you down regulate? Giving
Lupride depot preparation, GnRH depot. Down regulation with FET, how we do for endometriosis, same way. Same way.
Definitely, these patients are also having concomitant adenomyosis, so it does help that way also.
Because it's a chronic inflammation. See, PCOS is a chronic inflammation.
Yeah.
So this inflammation has to be basically taken care. You downregulate. How endometriosis also with downregulation it helps is a chronic inflammation. So same way, if you apply these patients also makes a lot of difference. You get a result. You see your patients and then you call me.
Okay.
Okay, ma'am.
Thank you, ma'am.
So here, is there a role of dexamethasone in resistant PCOS with normal DHES? So we are not talking about non-classical CAH here. This is normal DHES, normal
Probably,
HP
yeah,
levels.
probably it may help, but
So, ma'am, we have done it in 1 or 2 patients. We don't have a big series of these where we have tried dexamethasone. But this paper, this was published in 2024, wherein meta-analysis of efficacy of dexamethasone and clomiphene in the treatment of polycystic ovarian syndrome, and they said that it can be helpful to improve the ovulation rate. It was a total of 12 literatures were finally included with total of 1270 patients. And they found that if you add dexamethasone in resistant PCOS, this may help. Another paper on
It
this.
does help in a patient with, acne
No,
and
this is a
hirsutism. In
normal
those
DHES.
populations.
I mean, this is a simple clomiphene resistance, not a CH patient.
Yeah.
So if you and those.
Another patient where it was clomiphene citrate resistant and dexamethasone was given and it helped. So there are many papers on this. Even
high
letrozole,
dose, high
even
dose and
letrozole,
short course.
there are so
High
many.
dose, short course. High dose and short course.
Yeah. So there are so many papers on clomiphene resistant, but people are not talking about letrozole resistance still. So this is one paper on letrozole resistant polycystic ovarian syndrome where they have given dexamethasone and they found benefit. So that is one thing which can be tried, not very expensive, and it may help our patients. So with this, now we come, go on to case 2. Should we take case 2 or should we go on, ma'am? If ma'am is here, we can go on to a lecture also. Or we can just quickly do this case.
Dr. Niti, please quickly go to this the case, but we need to start the lecture because madam is there.
Yeah.
So
That's
you can take the second case ASAP, and as early as possible, you can wind up the panel, please.
My connectivity is so fragile. It's raining like anything here. And
Hello, Bharti ma'am. Good evening.
We can
Good
stop
Evening
it.
after a very, very long time.
Dr. Niti, can we have a lecture? Can we have lecture of Dr. Bharti ma'am?
15 minutes and complete and then you continue.
Okay, ma'am. Okay.
I think we can stop
Most
here.
welcome, ma'am.
Thank
Most
you.
welcome, ma'am. We are eager to hear you, ma'am.
Thank you. Thank you. Thank you
go
so
on
much.
Sharing, ma'am.
First of all, congratulations to the IFS chapter Raipur and the SIG PCOS. Dr. Anuradha, such a nice, good person. You know what? I have actually stored your number with a good person. Niti was asking me, what is now spirituality is coming to me. So this is all actually looking at the people, how they are getting that vibes. So thank you so much, Dr. Anuradha, Dr. Niti. You have taken over PCOS SIG group and you are doing very well. I'm very happy. I could see Dr. Both the Abhas, which were very interesting to see them and listen after a long time. Shweta, Dr. Pankaj Talwar, IFS President, all. Thank you so much. And all the team members, I think Niti, Parul, Srini are been here on this forum. Thank you so much. And today we are going to see PCOS and infertility. How can you solve? You must have seen now with that panel, there is so much of a puzzle and discussions. Patients doesn't come with one single way, like she comes with a ovarian tumor or not. It is always a different phenotypes patient comes. And depending on the phenotypes, you start wondering how to do the patients. You know that PCOS actually, second slide. Yeah, second slide. It is a heterogeneous and it is a reproductive metabolic pathological disorder. And this is basically main cause is the ovarian hyperandrogenism. And this associated with insulin resistance and obesity. And this major symptoms is menstrual disorder, hyperandrogenism, metabolic syndrome, and infertility, which we are now concerned. Next. So to diagnose as adolescents, they say, take it out sonography, and remaining two are the adolescent PCOS. But we remember in infertility and reproductive, we need PCOS, that polycystic ovarian morphology on the sonography, because it's very important to see increased follicles, stroma, and ovarian volume. And depending on that, I will tell you in the next slides, how can you differentiate different PCOS on only on sonography also. And one side, you know, the clinical features, one side, you know, that we have to have irregular menstruation, we have to have biochemical features, and then polycystic. If three are there, PCOS, two are there, PCOS, any of the two. So this is how the PCOS actually is diagnosed. Next. Now the second type of PCOS, this is all we know. The second type, you should know, some PCOS are LH driven and some PCOS are insulin driven. Next slide. So LH driven PCOS, is one of the panelists was saying, when will you do the laparoscopic ovarian drilling? Lean PCOS, high LH, high impaired GTT, and they actually respond very well to the ovarian diathermy. But still, now additional one thing has come into this four features is the AMH. AMH, anti-Mullerian hormone levels are very important. If suppose you drill the ovaries between 3.5 to 6, this patient over a period of time will go into premature ovarian insufficiency, because they don't have enough, they have just above the normal levels. But if you drill the ovary from 6 to 8 or 9 AMH, these patients will respond very well. But if it goes more than 9 or a 10, these patients again will not respond the way you are expecting, because it's too much of AMH, and 4 only drills and 40 watts is not enough for that ovary to start initiating. So remember, in the fifth factor is AMH. The AMH should be between 6 to 8 to give you the best response of ovarian diathermy. Never drill the ovary when there is a 3 to 5 or 6 AMH. This patient eventually will go into premature ovarian insufficiency. Then the second part is the insulin driven. When there is a central obesity is there, acanthosis nigricans are there. And very importantly, she has a longer intermenstrual intervals, like 3 months, 4 months. It is not 2 months or 1.5 months. These patients are usually insulin hirsutism score to something around 14 to 16. So these are the two subtypes. So write it down whenever a patient comes to your table. Is this patient is LH driven or insulin driven? How it will help in your management, I will let you know later. But you should write it down. Number one, you should write it down which phenotypes you are looking at. Like if the patient has got irregular menstruation and she has a biochemical hyperandrogenism in the sort of, say, maybe hirsutism, write it down HA plus IR, or she has HA, IR and PCOM. Depending on that, the patients will start getting management. The second part you should write, subdivide, insulin driven and LH driven. And then you will understand how to deal with this PCOS patient. Next slide. Now, this is the sonography, what I was telling. These are all 4 PCOS patients, all PCO morphology. Number 1 is also PCOM, number 2 is also PCOM, number 3 is also PCOM, and 4 is also PCOM. These are the 4 phenotypes on the sonography. Now, if you ask me which one is better for me, so many a times delegate says me, this one is better, where you will see a patient is a regular menstruating, she has a PCOM, but there is a dominant follicle here. Now, once the dominant follicle is there, you know this is ovulatory PCOS. No, this is a better PCOS, definitely. But this patient will give early pregnancy loss. So be careful in these patients. They will lose the pregnancies if you don't look at their insulin resistance. So insulin resistance has to be kept in the mind in these patients. These patients may not require your ovulation induction agents also, and she may stimulate on her own also, and she may get pregnancy also. Now, if you look at the these are the two one, which one is better? Looking at this, you see the follicles, they are 6 to 8 millimeter follicles. They are here, they are 2 to 4 millimeter. Look at her stroma, it's a thin stroma, it's not a very big stroma. But if you look at here, this is a very thick stroma. This is a typical resistant PCO. So whenever you're doing the sonography, remember these different things should be looked at and written. If this type of a PCOS comes, this patient will require a low dose to start with. Even with 75, they will start and they'll get stimulated very easily, and hyperstimulation is a very big problem. And even if they get the very good stimulation, pregnancy rate is very low in these patients. These patients will require a lot of care even for the pregnancy. It's like embryo transfer or embryo quality, and everything will be very, very difficult here. Now, this patient to start with is very difficult for this patient because they have a very high threshold. If the threshold is very high, sometimes your 225 is also doesn't match to this patient. And on the top of that, if she's obese, she will require a higher dose to start with. But once they stimulate, this patient gets a better pregnancy outcome. So this is different types of phenotypes here. Now, looking at this PCOS, upper corner on the left side, this is also PCO, but somehow it doesn't
Can
look.
you use a marker? We cannot understand which one you are referring to.
Correct, this one. So now suppose upper corner PCOS, is the patient is there. This is what is the difference in this patient is the age. These patients all are 28, 30 years and 31 years, and this patient is 36 years old. The moment there is a 36, you will not see many follicles over here. Hyperandrogenic, and this is very, very difficult patient to stimulate. And even if you stimulate also, this patient will not get enough follicles and enough eggs also. So don't get worried about that. She will have that much only because of the age. Now that is ovarian reserve is going down, and that's why the follicle. But the syndrome will be there with her. So stimulate properly, whatever way and whatever number is coming, don't expect more than 10 or maybe 15. This patient doesn't require anything else rather than just understanding that this much only will be the yield from this ovary. So this is the way you start looking at the ovary and the sonography differently and start getting stimulation. Next slide. So why this all happens? Actually, we all know that it is a stromal echogenicity and stromal volume, which is very important. And this happens basically because of the high circulating insulin levels and exaggerated LH pulsatility. Actually, what is the difference in the normal patients and the PCOS patient? Their pulsatility is very high. And because of the pulsatility, high pulsatility, she will have multi-follicles, more stroma, and high androgen production. Next slide. Yeah. So this is another way of looking at me before that. Another way of looking at the sonography. Now, whenever you see peripheral cystic pattern, which is usually associated with the abnormal gonadotrophin secretion, and when you see a second, that is general cystic pattern, which is associated with the ovarian steroidogenesis disorder. Now, when it is a steroidogenic disorder, these patients immediately, the moment you give the gonadotropin, they will start getting a very good follicular growth and you will get the stimulation. And when there is a ovarian steroidogenesis disorder, you require to understand whether you require FSH in her or LH in her. There may be LH ceiling effect in these patients. It's very important to understand. So next slide. So then this is a 2-cell 2-gonadotropin therapy. Actually, we all know that. And this is how it works, that whenever there is a granulosa cell starts proliferating and the androgen, say, theca cells comes, androgen goes into the granulosa cells, aromatization happens, and the estradiol and estrogen estradiols get secreted. Next slide. So this is the what I was telling you. Menstrual pattern in PCOS has to be seen. This is how I explain to the patient what exactly is the PCOS. I think I'm moving the cursor, but it is not seeing, right? Because the slides are with her. Yeah, this is a normal. Yeah, this is whenever I say any female gets, suppose, a period from first to first. She gets the period only because she has the in between middle of the cycle, she ovulates, and that's how it is called normal ovulatory function. Now if the patient gets a period 1.5 months, she will have delayed ovulation. If she gets 2 months, then again she will have a delayed ovulation. And sometimes she doesn't get the menses unless you give the tablet, that is called anovulation. So this is ovulatory dysfunction happens in your body. And this ovulatory dysfunction is because of the hormonal imbalance in the body. And the major two hormones are imbalanced in your body. Number one is androgen and another is insulin. Androgen is high and insulin has a resistance. So this is how your menstrual pattern has to be understood. Ovarian volume, follicular number are very, very important, and they are absolutely different when you see the metabolic findings in this PCOS patient. Next slide. So next, it is the same. So they say ovarian volume, but not the follicular number, appears to predict the metabolic abnormalities in the population of PCOS. So that means follicular number, truly speaking, sometimes doesn't make much difference in the metabolic abnormality. And ovarian volume is very, very important in the physical biomarker of systemic hyperinsulinemia. And this was actually the result and discussion. This is a beautiful paper. You can take down this paper. They're saying that PCOS and ovarian volume, it is more than 10 cc, that means 2 times, they will have more likely than ovarian volume less than 10 cc to exhibit the markers of insulin resistance. So this is a new way of looking at the ovarian volume. So if you are not doing the ovarian volume, start doing the ovarian volume and start little bit correlating your insulin resistance. Large number of patients reach the follicular number more than 12, but not associated with the metabolic parameters. And newly recommended follicular number cutoff is 25, did not display more metabolic abnormalities. So many a times we see 25, 50 follicles are there, but the patient doesn't have metabolic abnormality. So this is how this paper actually was saying. So just for interest, I had taken this paper. Next slide. So now investigations, as everybody was discussing, total free testosterone you can do, DHA, but there is no need of doing testosterone unless you feel she has really high hirsutism score. Otherwise, you know that she has high testosterone. But then theoretically or research oriented people, they will do this all test, LH, DHEA, and total of free testosterone. Next slide. So how you can interpret these investigations? Whenever you do free testosterone, it should be more than 4 picogram per ml. And androgens, when you do, actually androstenedione dione actually is the main ovarian androgen. It should be more than 3 nanogram per ml. And you should take out the free androgen index, that total testosterone into 100 divided by SHBG. And that if it is more than 5, it is seen in the PCOS patient. And FSH-LH ratio, you know, SHBG less than 40, and sonography. Next slide. So these are endocrinology which we see in the PCOS patient: high fasting insulin, high androgen, high LH, low SHBG, free androgen index, high estradiol, high prolactin level. Now, how does it make difference in your clinical practice? So we usually tell the patients that, see, these are the endocrinological disruption has happened in your body, and I would like your insulin level to bring down, your androgen level to bring down, your LH level to bring down, your SHBG has to go up. So this is how, if you start now, these IT people telling them like this, they get very easily convinced and they will start getting the treatment for 3 months or 6 months whenever you've been doing suppose if they are not interested in infertility, for just regularizing their cycles. Next slide. So this is how it helps for me. So in PCOS, it is altered GnRH dynamics, increased pulse frequency, LH pulse frequency and amplitude. Frequency and amplitude, when it is increasing, remember that this is very difficult that LH level to bring down. And if the LH level is continuously high with tonically high LH, your follicle stimulating hormone will not act and the granulosa cells will not start um, increasing or proliferating. Because in the theca cells, the LH production happens, and that from LH, the androgen will get dissolved into the granulosa cells. Aromatization happens, and then the estradiol. Thus, the only follicular growth is going to happen. If there is a tonically high LH, believe me that excess androgen will not at all enter into your granulosa cells, and that's how LH has to be going down. And LH, unless you take that seal off of the LH, this patient doesn't get stimulated. Next slide. So increase in GnRH pulsatility will have increased androgen synthesis and inhibition of folliculogenesis. This is what was happening in that patient. So what has to be done? Suppose I'm giving you an example of my patient very recently done. We started, actually this was a donor PCOS, and she was being stimulated somewhere in the other center, and then she sent it to me the 5th day of the sonography scan. She said, madam, this is not growing, all the follicles are 6 to 8 millimeter, and this is 10th day, I think 7th day, all the follicles are between 6, 8 or 9 millimeter. Now I asked her, what are you giving? She was giving HMG to this patient. Now, don't completely abolish that cycle. We know that now if she is giving HMG and so many follicles are there, but none is going ahead, that means I need to take out that LH. So I said, stop her HMG completely and start only pure recombinant FSH, 300 units. Don't give less dose, but 300 units. In 2 days' time, you will see this follicle starts growing, because you have not given her LH and you are pouring the FSH. That means her follicular genesis will start going ahead. And the 10th, I think 7th day she said, 9th day she said, yes, madam, now they are 14 millimeter and 13 millimeter. Now I said, this is right time to give her antagonist. Now continue FSH like this only for this patient. Do not add LH at all in this patient. Will require will give a very good yield at the end of 10th day or the 12th day. So this is what is actually LH ceiling. Next slide. So this is a physiology which is going on. So there is called LH threshold. Means initially you need little LH. To cross that LH is very important. That is called LH threshold. In between, you will know that there is called LH ceiling effect, mid follicular phase. That ceiling effect should be taken it out by giving your FSH higher dose, only pure FSH in this patient. And then lastly, you know that aberrant LH peak will be there. That is for SCG, that is a maturation surge. So there are 3 things in the LH. Initial phase, you will have a LH threshold. In between, you will have a LH ceiling. And then lastly, it will be LH surge. So you have to manage that LH from outside with your gonadotropin stimulation or the treatment. So we all know that this is all is the problem with the PCOS patient. They have a gonadotropin aberration, insulin resistance, hyperandrogenism. So how to overcome these all? Next slide. So with the ovulation induction, so we all actually see ovulation induction when there is no ovulation is occurring. That's called induction. Means you are inducing that form ovary to make one single dominant good follicle. That is called ovulation induction. And when you have been stimulating for more than one follicle, 2 or 3, we say it is hyperstimulation. It is called controlled ovarian hyperstimulation, or you can say super ovulation. You are doing. We aim 2 to 3 follicles in IUI, and maybe 10 to 15 or 15 to 20 follicles in IVF cycle. So this is the two different ways we look at. So what is the ideal ovulation induction protocol in PCOS patient? We have to have minimized the medication. Compliance should be very good. Number of multiples should be reduced, means multiple these pregnancies, no hyperstimulation, no cancellation. Very importantly, see, I always tell my all residents and people over here that cancellation is very easy. So when you are supposed doing MTP and there is a perforation, do you cancel that cycle, the case? You don't, you rectify that. Where there is a perforation, I have to close that perforation, or I have to see, like that you start thinking. You don't cancel patients at all. You have to think what is happening in this patient. So unless you think it will not be revived or it will not be corrected. And we don't want miscarriages. So we don't want cancellation. We don't want miscarriages. We don't want multiples. We don't want hyperstimulation. And plus we want ease. So this all can be achieved nowadays in PCOS patient. Only you must know the physiology which is going on in that patient. Next slide. So whenever you're doing sonography, you should start thinking what physiology is going on inside. So if you start thinking, this will work very well into your mind and your patients. So can we individualize? Somebody was saying CC or letrozole or gonadotropin, depending on the E2 level, whether it is low or high. So whenever you have a low E2, that means you need not to do E2 level. Just look at the patient and you will come to know this is a hypoestrogenic patient, thin patient. So these are the hypoestrogenic patient. They will respond very well with CC and gonadotropins. And whenever there is a high E2, that obese patient, these patients will respond very well with letrozole. Next slide. So this is how the hormonal profile I see. If you start looking at the hormonal profile and you understand whether this patient has a hyperestrogenic, hypoestrogenic, no need of doing E2. But if your FSH is too low, remember that she is a hyperestrogenic. Because when the FSH is low, then only the estrogen is going to come from the hypothalamus. So remember that how to understand your present gonadotropin, biochemical markers or biochemical investigations, patient between hypoestrogenic and hyperestrogenic. If a patient is hyperestrogenic, this patient will well work with the letrozole. If it is hypoestrogenic, patient will work well with the clomiphene citrate or maybe gonadotropin also. And if the patient is suppose hypoestrogenic and the patient has got a high AMH, this patient will work gonadotropins better in this patient. So like this, we start looking at all the parameters and start putting the patients in the stimulation cycle. Next slide. So different types of, actually, we know that the clomiphene, I'm not going to go into the detail because you have dealt with this modification. You can have a step-up protocol. You can add the aromatase inhibitor. You can add the gonadotropins. Next slide. Next slide. Next slide. I think this has been done. So we'll not do extended protocol. I think one of the panelists was saying. Next slide. Next slide. Next slide. So we, in this patient, we'll get prior, before, either we have a ovulation failure or we have a conception failure or we'll have a pregnancy loss. Depending on that, you start choosing your protocol for this type of patient. Next slide. So you all know that this is the diet and exercise. This is a therapeutic plan. Next slide. Yeah. Now letrozole, somebody was actually discussing the letrozole. I have never seen the thin endometrium in letrozole patient. Letrozole is a potently estrogen inhibitor. So because of that, her endometrium, many a times you see a very thin endometrium and you see the breakthrough bleeding in this patient. So if this has been happening, that means there is a called letrozole resistant patient. These patients has to be switched over to the gonadotropins. There is no option for this patient, or you can add letrozole with gonadotropin for these patients. But in these type of a patient, suppose you add estrogen, it's a low endometrium, thin endometrium is there, and you start giving a estrogen, estradiol for this patient, we were thinking that it will work. The endometrial thickness used to give a little better looks, but somehow implantation doesn't occur. That means there is no glandular hypertrophy or glandular proliferation doesn't happen if you only give estrogen from outside. So it is always better to give a gonadotropin in this patient. Next slide. This was the first concept study where we all started using letrozole. This is, I think, protocols. I think we will stop here. Can you just share me the whole slide so I can see what important things has to be? So I think this is all is done. Next. So this is a WHO recommendation. No, previous slide. So here I want to little differ. The WHO recommendation is like you give aromatase inhibitor, clomiphene in the first line of management. The second line of management is the gonadotropin or the laparoscopic ovarian drilling, and the third management is IVF. Here I want to change now. This is a paradigm shift right now. WHO was been long back is given this map to us. But we as a clinician, we have started understanding that if a patient coming to you is a PCOS resistant patient, in these patients, it's very difficult to stimulate for IUI. It's very difficult because you can't increase the gonadotropin dose because you know that if it increases, threshold goes up and she will go into hyperstimulation. You don't even know whether this patient has to be converted into IVF or to be left alone. Living alone is also difficult for this patient. So now the paradigm shift is that the patient who is a resistant PCO patient, where you know that with giving a minimal dose, she's not responding for 2 to 3 follicles, these patients will directly go for IVF. Now, doing IVF, you have liberty of giving a high dose to her, and giving a IVF, she will have 15 to 20 eggs and she will have 4 to 5 good blastocysts in your hand. Now, in this patient, the pregnancy rate is much, much better than just trying your IUI for a long period of time and not getting stimulated. Not in that period of time, patient is now going to slowly cross 30 years, 34 years or 35 years of age, and it's not going to be a fun for that patient. So a new paradigm shift is that the patient who is more than 30 years, 32 years of age, and a resistant ovarian syndrome, she has polycystic ovarian syndrome, patient, start convincing that patient IVF would be the first line for you, not clomiphene citrate or a letrozole or this thing, but IVF give you a better cumulative pregnancy outcome for her, and no miscarriage, less miscarriage for that patient, and she will have best compliance. And we are now compiling all our data for this type of patients, a resistant PCOS patient especially. They are going pillar to post for, they keep changing the table because nobody knows how to optimize 2 to 3 follicles in this gonadotropin resistant, this PCO resistant patient. So this is how is the new way of looking at the PCO resistant PCOS patient. With this, I think I will stop here because I think this is all is been done. Drilling and what is the lab. This is, I think we have done all this. So
thank you so much, ma'am.
Thank you so much.
I'm so happy that you brought
It
about
was the
that.
patient actually. This was the last, I said, man, that LH, this thing, hyperstimulation, they will take care of that. We all know nowadays hyperstimulation free clinics, and we can do that because of, I think we can give a GnRH agonist, and we all know that vitrification is one of the best way to do. And IVF FET cycles, if you start optimizing them, they give a very good pregnancy outcome without having any hyperstimulation. Hare Krishna, thank you very much. And Dr. Niti was asking me what I do as a spirituality. I have actually started following ISKCON, and Actually, we all had the problems, why good things happens with the bad people, why bad thing happens to the good people. What is the purpose of the life? It was going on in my mind also. Many questions were there in my mind. And then when I came across the Bhagavad Gita first class, classes, and I started realizing, getting my answers to it, and then slowly, I started getting involved into that spirituality. And today I'm so happy that I have even completed my post graduation is spiritual diploma. I have read many literature, scriptures, which we usually don't know. And in that literature, when I saw scripture that is called Bhagavatam, which is a third canto, each and everything of IVF is written. Everything. Can you believe that? Every detail is written. So it's something 5,000-10,000 years back, when there was no microscope, nothing. And how could they see two cell? Who is more important? Egg important and the sperm important? When exactly the life starts, and how that cells happens, and how the human being happens. This is all was very interesting to me, and that's how, Niti, I'm now more into that. So I've restricted my lectures and all those things, and I'm more focused on that.
So good
and
to know
I'm
that,
really
ma'am.
enjoying my
Ma'am,
practice.
it's a proud privilege for Raipur Society to have you as a speaker.
Thank you so much.
Really a wonderful
Very
lecture, ma'am.
so
Really wonderful.
Can I make a comment
And
here, Dr. Sushma? Can I
yes,
just make
yes,
a comment?
yes, ma'am.
So, ma'am, what? I'm so impressed by the paradigm shift which you were talking about, because we many a times we encounter such patients where it is very, and now the guidelines are so strict. They say for two follicles or more, you have to cancel the cycle. So up to two follicles only you can do IUI. And if you end up with triplets and quadruplets, you will be taken to court now, because the guidelines are very strict about it. So many a times it is difficult in some patient to get those two or three follicles, and we often
very
shift them
different.
to IVF straight away. And I used to think, that I have failed somewhere, that I have not been able to induce her, and I have taken her to IVF. But it's so
It
good
is
to
correct.
listen to you
And
that
you see, have you seen that these patients, you gaining 2 to 3 follicles, you start, giving better protocol, everything. Look at her endometrium. It doesn't,
yeah.
how many times your endometrium matches with your dominant follicles? You see, it's a very difficult to match that endometrium. And if your endometrium is not matching, it's not triple line, it is not giving that good morphological features, how that embryo is going to come and get implanted over there? And even if you see the PCOS patient, 25 follicles we get in IVF, we get 3 to 4 best quality blastocysts. So how many eggs are being wasted? That many cycles she will have to waste.
Yeah.
See, whenever there is one follicle, we don't know whether that egg has got that good quality egg, whether it is going to give a good embryo which is going to get implanted. You have, so what I have started counseling my patient, beta, I am not doing IVF for you not getting pregnant. I am doing IVF for the selection.
Yeah.
I'm selecting now. I want to be selective. How many good embryos? Suppose I get 3 to 4. I know these are my best seeds. I will put them at the right time when your endometrium is going to be good, and you will get the pregnancy outcome very good over there. So this is what is the different counseling altogether. Many a times RPL patient comes, right? Many a time PCOS patient has got a recurrent pregnancy losses also, because they have early pregnancy loss. So they start thinking that I'm fertile, I'm going to get pregnancy. So doctor then is, why IVF is for the pregnancy? I said, it is not for the pregnancy. I'm not doing only for pregnancy. I'm doing selection for your embryo. IVF is for selection rather than only electively doing your stimulation, because I do not have any control. I always tell now IUI, very less IUI I'm doing. Yeah. In IUI, what I say, I have, doctor, how much is the pregnancy rate? Patient usually asks, what is the success rate? So I always tell them, I have 10% only control in this cycle. 10% only control. Means I can give you medicines, I can see the follicle. I don't know anything else after that.
Yeah.
So that means my control is only 10%. Suppose you have 10% control on your children. How much? How will you come to know that 10% only you are seeing? Other all time, day, night, the child is outside. How you are going to control and how will you see the success? So if it is 10% control, 10% success rate. So you tell, I have a 80% control in IVF. I may give you a 70 to 80% success rate if I select the best embryo and best IVF lab outside. So this is how I think the counseling, it is we have to counsel the people because we know that we are struggling for that. And openly, very less people talk about this. Again, bookish.
Yeah,
All
very less people
we
tell
are
this that they will be patient.
Ma'am,
and
just
even
once
and
you said
even if
the
you're
case of
doing also,
RPL, I want to discuss a case with you. I had a patient of 8 spontaneous abortion, PCO patient.
yes.
And patient is repeatedly telling me, ma'am, why you are advising me IVF? Why you
बस
are
उसको यही
advising me
बोलो आप
IVF? Then I
आपका
said
काम
that you said I am going for embryo selection, and then I did blastocyst transfer, and she is having twins, two very good matlab,
in
child
pregnancy.
nowadays.
Yeah. That's what I'm
So
saying. This is how you have to now start changing your counseling from infertility to fertility. No, fertile you are. You agree to that. I'm going to give you the better pregnancy, maintenance of pregnancy, selection. So
Ma'am,
then,
I have one doubt. If a patient with PCOS having E2 more than 300, 400, even if you have given OCPs for 2 cycles, 3 cycles, it's not reducing. And you have to go for IVs, then what you have to do?
doesn't matter, you go with the stimulation, but these patients will require a high FSH. Like you know my IGT score, I can send you that. There are criterias. Depending on those, you calculate the dose, and that dose you start with day one. First 5 days your recruitment. So
Yeah.
you have to stimulate. The moment you start recruiting best follicles, you're going to get the best outcome. So recruitment should not be slow, because that is where we start actually failing, because we get scared of hyperstimulation. You need not to scared of hyperstimulation, because now we know right and left and everything we can do for the hyperstimulation to avoid. This patient will require a proper starting dose for 5 days. First 5 days, a proper dose of gonadotropin. I will send you that IGD score ka score system, and
Yeah.
you calculate her age, then response, previous response, then AMH, antral follicle count, and all those things. You calculate that, and depending on the score, there is a doses. You start that dose.
And should we start letrozole with the gonadotropins for this patient? Like estrogen is 400.
IVF for IVF?
IVF.
No letrozole for this patient. No, don't start, because you will get a less yield.
Yeah.
You need more. See, number is very important in IVF. Number of eggs are very important. You need to select. So numbers are very, very important. So letrozole will not give that number to her. So you can give CC to that patient, and FSH, I will tell you the dose. You start with that dose, she will get a better yield. And no transfer in that same cycle. No transfer. And that patient will require down regulation with FET. She'll get pregnant.
Right.
Down regulation with FET. These are the new two things: growth hormone, resistant PCO growth hormone. Don't look at the 8,000 rupees. She will respond very well. Secondly, down regulation with FET. Three places I do down regulation with FET and get a very good response. Number one, endometriosis. Number two, resistant PCOS patient. And number three, unexplained infertility patient. Unexplained infertility. And where the patient's age is more than 34 years of age. Those patients downregulate and FET get the better pregnancy outcome. The last 3 months, we have touched 76% pregnancy rate. So individualization of your luteal support is very important depending on this. And luteal support, if suppose for example, failure patient comes, IVF patient came as a failure to you. The day she comes as a failed, beta ICG is low, do her sonography scan. If your scan shows thin endometrium, see, ideally there should be hyperestrogenic, thick secretory endometrium, like fluffy endometrium should be there, because you are giving so much of progesterone to her. And if you look at that endometrium and if it is thin, that means where is your progesterone gone? Your progesterone is not reached only in our body. That means there is a progesterone receptor deficiency or resistance is there. Now you need to upregulate that LH receptors. Now upregulation of LH receptor will be with luteal support with GnRH agonist injection. Those patients get conceived. So this is the fourth different things what we do. So thank you so much. And thank you for accommodating me, Niti. I'm extremely sorry I came in between the panel. But I
really very informative.
I thought that मेरा net गया तो वापस गए. So
Thank you so
Is
much,
it
ma'am.
raining
Thank
on
you
that
for
side?
joining us.
Raipur raining?
Ma'am, little bit. Yes,
No,
it's raining on it.
no.
On it.
Raining like anything in Pune.
Uh,
Very, very bad raining.
And
Thank you
Mumbai is
so
also
much.
probably drowned, no, ma'am?
Yeah, that's what I'm saying. It is literally pouring. Literally pouring. So thank you all.
Thank you, ma'am. Thank you so
Thank you,
much.
madam. Thank you so much.
Niti, all the best. And
Thank you,
Doctor, all
ma'am.
the
Thank
best.
you.
Thank you, ma'am.
Thank you, ma'am.
Good program.
Thank you, ma'am. Thank you so much for wonderful lecture and your great. It is a great learning experience for all of us, ma'am.
Thank you so much.
Thank you. Thank you so much, ma'am.
Thank you, ma'am.
It was lovely, lovely listening to you.
Thank you. Should I leave now? Thank you.
Yes,
Ma'am,
thank you, ma'am.
but
Thank you
can
so much.
Ma'am, you can stay, ma'am. You can give your feedback, ma'am. The next one more case is there for panel discussion. So can you stay for 10-15 minutes, ma'am? Not more than that.
Okay.
Thank you, ma'am. Thank you so much. Ma'am, Niti ma'am. Hello. Niti ma'am. Stop sharing. Hello. Niti ma'am. Hello. Niti ma'am.
I think she has lost the connection. She is not there.
Yeah, she's not visible.
Dr. Parul can take it over.
She left or what?
Anupama, it was very nice to see you after a long time. Asha ji, lovely. Veronica. I think Parul can take over.
I think she is also not there. Dr. Parul?
Dr. Parul is there.
Parul is there, but I think
She
she's
is visible, but
yeah. she's
Hello.
there.
Hello, Dr. Niti has left. We think we should wind up the panel discussion. So she has left the. So can we wind up, or you want to have a second case? Because Dr. Niti has to take the second case.
I think it's time up also.
Yeah, because
Yeah.
it's
We
been
can wind up. I
7:30.
think we have had a
Time up.
Wind up.
session on PCO. We've covered almost everything.
One case करो ना. One
Hello,
case
Dr.
करो.
Anupama.
एक case है. पारुल आप बताओ. सब पैनलिस्ट सब प्रिपेयर करके आए हैं.
No, we should wind up.
Ma'am, we can have
It's already 7:30.
but we should end up in a short time.
Okay,
because it's already 7:30, I think.
Yeah, it's 7:30, so we should.
Okay,
Yeah.
we can wind up. Fine. Because there's next two cases are already on gonadotropins only, so we have discussed that.
That too, madam has already covered.
Yeah, that ma'am has already covered. There's
Yes.
nothing new.
Chalo, theek hai. Okay then. Nice meeting.
Okay, then it was really lovely. Good interaction was going on.
Thank you.
Yes.
Thank you all my
Thank
dear
you,
panelists,
Anuradha.
experts, Bharti ma'am, our speakers, our moderators. Thank you for being with us today and having a great panel discussion, as well as both the speakers were wonderful, and all the lectures and the discussion is very beneficial to all of us in our day-to-day practice. Thank you very much for being with us today.
Thank you. Thank you,
so much.
Anuradha. Thank you for inviting us. It was really a wonderful discussion. Got to learn also, not only to give any inputs, but got to learn also. And very nice interaction with the panelists. It was wonderful webinar.
Thank you.
Congratulations.
Thank you.
Thank you so much. Thank you.
Thank you everyone for all your presence and so interactive discussions. Thank you everyone. Now, and rather, Dr. Angada, please go to
Thank you all of you for your presence. Thank you, Abha Majumdar ma'am, Bharti ma'am, Abha Singh ma'am, Asa ma'am, Sarita Agrawal ma'am, Susma ma'am, all my seniors and colleagues to join this webinar. And I think I hope we all have gained knowledge so that we can treat the patient individually and we'll get the good pregnancy outcome. Thank you. Thank you so much. And thank you to Corona Remedies to give this platform of webinar. Thank you. Thank you again.